At the beginning of the first segment, we are lucky to have Dr. Nathan Shippey. He's the principal investigator of ResDAC, and he is also an associate professor at the Division of Health Policy and Management at the University of Minnesota. He's a sociologist and a methodologist who's done a lot of work in complex patients and chronic conditions and mental health. So we're very lucky to have him for our first segment. So I will turn it over to you, Nate.
Thank you. I guess I'll kind of get us rolling here. So, kind of introducing ResDAC a little bit. First of all, we have our mission, and I think there may be sometimes people I think have different they get different experiences in working with us, or get different ideas about what our actual mission and goals are. So our mission is to help CMS increase the number of researchers that are skilled in accessing and using CMS databases for studies of the Medicare and Medicaid programs and beneficiaries. Okay. So, and again, I would just emphasize to increase the number of researchers skilled in doing that. We have a number of different kind of tasks in our statement of work, in our scope of work. The biggest one by far is our assistance desk. And the assistance desk is staffed by who we call our TAs and EAs, or our technical advisors and executive advisors, who do various things for assistance, including answering questions regarding the data, as well as data access and availability and the record layouts, and individual variables. We have, they help people in terms of location of the Medicare and Medicaid program information. And also, very importantly, they work with researchers from the first inquiry to submission of a complete request to CMS for data. As part of that work, or in doing that work, they also support all the content and everything that you'd find on the ResDAC website, which if you haven't visited, I would. There are a lot of resources there. We do also, another part of our work is to do these types of workshops throughout the year. We sometimes will run a different slate of them, but for this year, for instance, we are doing the Introduction to the Use of Medicare Data for Research. That's our 101. We've already done that. We kind of do them quarterly, roughly. We're doing... Now, of course, we're doing the Introduction to the Use of Medicare Part D. We will be doing the use of encounter data. That's for Part C. And then we do have a Medicaid workshop that we've recently kind of reintroduced based on newer data submission and collection system called TAF for Medicaid. So it's our TAF workshop. That is our Medicaid workshop. That'll be in the fall, I think in October. Also, as I mentioned, our website, that's a big chunk of the work we do. Not necessarily as big as our assistance function, but it's used by a lot of people. Has a lot of different, not only resources, but also really key information and forms and other things that you'd need in order to submit a data request. So you've got all kinds of things like request process and forms and other things for your data use agreement management. Managing your DUA is an absolutely key, central, and vital and required part of accessing the data. So that's a big chunk of the important work there. As well as information on data availability. We've got different files that are released kind of with different periodicity. We do have workshop recordings, not of every single workshop all the time, but we are continuing to update those. I would say that the workshops we've offered the most tend to be the ones where we definitely do have ready recordings. And other than asking questions, looking at the workshop recordings online really is, you're getting the same content as if you would attend a workshop. So if you're not able to get signed in or registered or something like that for a workshop, looking for the content online on our videos is very much the same experience. Again, other than asking questions, which of course you can always submit questions through our website. We also have things called knowledge base articles. And just anecdotally, I know that a lot of people use these. So if you're not familiar with them, these are kind of not exactly technical reports or anything, but they're very brief technical articles. Some of them very high level or introductory, some of them very down in the weeds on different aspects of the Medicare and Medicaid data. And so you'll get all kinds of things in there about specific variables and little quirks in the data and things like that. And those are usually written in response to user questions and things like that. But there's a whole kind of library of those. And we are continually kind of asking CMS to approve new ones as we find new areas. So digging around in the knowledge base articles, if you're a nerd like me, is really fun. You learn lots of different things. And then lastly, we've got other videos on specific topics too. And I think we continually try to update our content. The only caveat I would give there is that I know personally that I have recorded some videos in the past that I wouldn't say I'm embarrassed about or anything, but are definitely, I would take some of the video content, look at when it was recorded, and make sure that if we mention something about data availability or anything like that, that it is up to date. Most of our workshop recordings should be very up to date, but if there are any other videos that you find, just make sure that the information is up to date before you act on it or that kind of thing. They may have been correct at one time, they may just need a small update, or there may be some things where files have changed or something like that. So just make sure that you take those as the historical documents that they are, that may or probably are correct now, but there may be some slight variations on availability and other changes that have happened with that last kind of category of videos specifically. Then lastly, we've got a number of different ways to contact us. So we've got our phone number. You can go to resdac at umn.edu or resdac.org, the website, for information. And then if you go to the website, it also does have all this contact information on it as well. So the website's a good one to remember because it also has all this information. And then these contacts are usually going to be staffed, as I mentioned, by our assistant staff, the EAs and TAs and so on. Will address different parts of questions and requests and so on. All right, so to kind of introduce the faculty, Steph already introduced me, so that's nice. And then I'm just going to kind of go through and introduce the rest of the folks who'll be talking today. I just want to say that, like, as I look through kind of different bios and information on people, it's just always impressive to me to see how many years of experience we have collectively of working with these data. So first of all, we've got Stephanie Rosick, who's in the Division of Health Policy and Management, the University of Minnesota, like me, is also the ResDAC Director of Data and Training. She earned her PhD in Health Services Research Policy and Administration from the University of Minnesota School of Public Health and specializes in using administrative claims data for research. She's got over a decade and a half of experience working with Medicare data, including Medicare data linked with other data, particularly the SEER Cancer Registry. Dr. Urasic joined ResDAC in 2015 and focuses on training and supporting researchers using Medicare and SEER Medicare data. Next, we've got Jia Zheng, who's a professor in the Department of Health Administration and Policy in the College of Public Health at George Mason University. Has 20 years of experience with Medicare data. Using varied Medicare data sets, she has authored numerous papers examining health service use or spending, quality of care, and health outcomes among Medicare beneficiaries. Analyzing fee-for-service claims data, Dr. Zheng examined how provider practice patterns change in response to new Medicare policies or market environments. Using Medicare Part D specifically data, she examined the relation between drug plan benefits and prescription drug use among older adults. She is currently analyzing Medicare Advantage encounter data to evaluate care provision for Medicare Advantage enrollees. She uses econometric approaches to infer causal relations in her analyses of Medicare data. So very glad to have her with us. And lastly, but not leastly, we have Becky Vick, who's one of our ResDAC data analysts. And I just have to say, I work with her on a regular basis on a lot of our data-related projects internally. She's just a great person to work with and has a lot of insight into kind of managing these data. She's also, of course, with the Division of Health Policy and Management here at the University of Minnesota. She's got over 20 years of experience working with various types of data. For nearly 10 years, she worked with large-scale demographic data at the University of Minnesota's Minnesota Population Center. The Pop Center here is a big kind of demographic and other data hub with a lot of different data sources kind of brought together. And then transitioned to healthcare data as a healthcare economics consultant for United Healthcare in their Medicare Advantage line of business. She returned to the University of Minnesota in 2020 as a data analyst with ResDAC, and we were very happy to get her. Becky has a BS in economics from the University of Wisconsin-Madison, although we will forgive her for that, and a master's of geographic information science degree from the University of Minnesota. So again, just really great to be able to have these folks present and bring all their experience with these data and other data sources and the insight that brings along. So just great to have that team. All right, so to kind of get down into introducing the Medicare Part D part of the program and some of the workshop objectives. So that one's on me. Here's where I reveal my knowledge and or ignorance. I would say I've worked with Part D data. I have a fair amount of knowledge of this program specifically. I'm a bit more of a Medicaid guy, and but at the same time, yeah, so I have worked with these data, but it's been a little bit. So the original structure of the Medicare program, if you look back, right, we have Part A and Part B, and I think most people here are probably familiar with this. But if you look, especially if you go to if you're interested in the Medicare program and you don't have a lot of experience with it, I would suggest going and looking at some of our workshop videos for our Medicare 101. Because there are parts of the program that are actually relevant for how the kind of the structure of the data. So beyond just policy alone. But in terms of policy, we do have Part A, which is hospital insurance, which also does cover things like post-acute care and hospice. And sometimes we talk about that as covering institutional providers like hospitals and again, skilled nursing and so on for post-acute care as well as hospice. Part B then really deals with what you might understand as non-institutional providers relating to outpatient and professional services. So the largest chunk of these are going to be things like physician services and other care providers that are not part of the hospital itself. So you could imagine also an example that I like to use is ambulances. There are some ambulance services that are standalone, and then there are some ambulances that are part of a hospital. And so if you were to, for instance, look in the data for those, you would find some of those in hospital-related files, and you'd find some in the other file that's called the carrier file, where we find physician services and things like that. But also we've got other types of services like durable medical equipment, and there are some drugs in the Part B program. Now, I do want to note there's an asterisk there. I do want to note that outside of the Part D program, Medicare's coverage of drugs is limited to a very specific kind of set of categories. So it's a relatively exclusive list, and usually it's going to be things like injectable and infusion drugs. I think there are some rare cases where you can have oral medications. I think is it ESRD? If there's an injectable type medication, but there's also an oral type, and if the injectable is covered by Medicare, then I think there may be some cases where an oral is also covered. So there's some rare categories, but again, in a lot of cases, we're talking about injectables and infusions. There are some vaccinations that are covered, those kinds of things, but it's definitely not the kind of list that's going to include, say, your metformin for diabetes, or a beta blocker, or a naltrexone for a substance use disorder, or any of those other kinds of things that you would find in potentially in Part D. Obviously, we've got the population in particular, and by far the largest category related to those age 65 and older. We also have what's called the disabled category, which is a very specific category. A person may be may have a lot of physical morbidity from a condition, but unless they are defined as disabled by the Social Security Administration, they would not fit into that disability category. That's an administrative legal category. But then we also have two much, much smaller, if you were to look at a pie chart, these would almost be not visible depending on the size of the pie chart. We also have two newer and smaller categories, those being end-stage renal disease and amyotrophic lateral sclerosis. So we've got ESRD and ALS as two much smaller categories for eligibility as well. Now, Part C, it's important to note that Part C, or Medicare Advantage, or Medicare Managed Care, and if people are not as familiar with kind of the financing of healthcare insurance in the United States, it's important to note that you may hear a number of terms for this. Part C, Medicare Advantage, and Medicare Managed Care, by and large, refer to the same thing. There are a couple of really specific cases, but by and large, if you hear Managed Care, Part C, and Medicare Advantage, those all relate to Medicare, the managed care alternative for Medicare. And it's important to note that it is an alternative in the sense that it doesn't add anything beyond Parts A and B services. So in other words, if you've got Part A benefits being inpatient and Part B benefits being other types of, or I should say, inpatient and or other institutional type providers, and then you've got Part B services that are kind of outside of those where you've got non-inpatient services. If you've got those kinds of things offered under the traditional or original Medicare, those are also the same things that are offered under Part C. It's just that Part C is this managed care approach to kind of paying for those. But we should, again, just to note that Medicare Part C at its base, now there may be Part C plan administrators or private plans that are offering Part C that add things into that, but that's not necessarily required or part of the Medicare program as a requirement. So again, not really any added things. Part C is best understood as an alternative to Parts A and B, or to paying for Parts A and B, compared to fee-for-service under original Medicare. So then beyond that, though, Part D really does add something different. And it can be through, original Medicare fee-for-service with standalone or prescription drug plans, or PDPs. You'll hear that term quite a bit. Or you also have Medicare Advantage drug plans. And so Medicare Part D was implemented in 2006 as part of the Medicare Modernization Act of 2003. So if you'll note, again, just keep in mind that Part C really doesn't add anything past the other parts of Medicare. It's just a different way of paying for those. And in the same way, when you've got the intersection of Part D and Part C, you do have Medicare Advantage drug plans, which are kind of the managed care approach, but are still bringing in these Part D type benefits. And then to kind of look at the share of things over time, and this really tracks with what we would see generally about regarding the penetration of Medicare Advantage or managed care in the Medicare program over time. You'll note that the lowest category here are the MAPDs, or the Medicare Advantage prescription drug plans. Okay, so that's Part C, Part D benefits, right? So we've got prescription benefits under Part C, or Medicare Advantage is the category at the bottom in the light blue. Next, we have prescription drug plans, or fee-for-service, that is Part D within the traditional Medicare program. And if you note, over time, the share of MAPD, or Medicare Advantage prescription plans, has definitely gone up, and that again tracks with what you'd see with the penetration of managed care in general in the Medicare program, as well as Medicaid, I would note. Managed care has become an increasingly large part of what we understand in both the Medicare and Medicaid programs. That has come with some carve out away from the fee-for-service part, that is fee-for-service under traditional Medicare. So if you're looking at Part D fee-for-service prescription drug plans, or PDPs, those have shrunk a little bit. They're still fairly sizable, and if you think about raw numbers, of course, we're talking about millions of people, but that has shrunk slightly. And then you've got some of these other things. So over time, and I think this really is also going to be tracking with the shrinking of the coverage gap, or donut hole, if you've heard of that in Part D. Over time, we also had this retiree drug subsidy, which was a separate subsidization program that would allow certain plans to offer kind of prescription type cover, or help them offer prescription type coverage kind of outside of the Part D program. Of particular note would be, again, as in relation to the large coverage gap that would exist between initial coverage and catastrophic coverage, which you'll learn about later in the Part D program as it existed originally, which has now been largely phased out. And so that's shrunk quite a bit. And then lastly, of course, you got people who are not enrolled in Part D. So we've got kind of different categories of enrollment there, but again, you can kind of see the large growth in Medicare Advantage, a slight shrinking in some of the other categories, and of course the retiree drug subsidy kind of largely going away, or at least percentage-wise going away over time. Now, if you're thinking about the actual data files, there are a lot of ways to split this up, but what we've got basically are, you can kind of understand the different files as related to the different types of services that are covered. So you've got, for instance, Part A services related to inpatient or certain other types of institutional provider services relate to, you'll see, if you're looking in the fee-for-service data, you might find the hospital inpatient file. You'd also find the hospital skilled nursing facility or SNF file, as well as hospice and home health files. Separate from that, as I mentioned, you've got these kind of non-institutional providers as well as certain types of services that are not inpatient that are provided by institutional providers. So these Part B services are kind of a big mishmash, but the largest by far file that you're going to find is the carrier file. That's where you're going to find physician services and a lot of those other types of things. So a lot of times if people are looking for services, they want to just stick with simpler files, but that carrier file is often hard to ignore. Beyond that, there are durable medical equipment, home health agency. And then I would note that even though the hospital is an institutional provider, it also provides Part B services, and that would be in, say, the hospital outpatient setting. So when you hear outpatient as a file, please take note of this if you're not familiar with the data. If you hear outpatient as a file, that is as a data file, not as a general term, outpatient refers specifically to hospital outpatient. It doesn't mean anything that's not inpatient. It means specifically hospital outpatient, which could include things like hospital office visits, as well as outpatient emergency department visits. So in other words, an emergency department visit that doesn't result in an inpatient stay. Those kinds of things you could find in a hospital outpatient file. But if it helps, when you name the outpatient file, put hospital in front of it. It means hospital outpatient. I've seen people have miscommunication when they had different expectations of what was in that outpatient file. It specifically means hospital outpatient. Now within the encounter data, I would note that the encounter data are available actually quite a bit more recently. So in 2015, the encounter data, which refer to Medicare Part C, became available. And that's what's really interesting about the Medicare Advantage. It's something kind of new, and we're still kind of looking at how those maybe might compare to fee-for-service data in the original Medicare data. But so again, those have things that kind of echo what you would find in Parts A and B: home health, inpatient, skilled nursing, and then on the Part B side, carrier, outpatient, durable medical equipment, home health. So a very, very similar set of categories there. And then you've got Part D, where you've got prescription D event file, and I would emphasize event, in a formulary, medication therapy management, pharmacy characteristics, and lots of other things. So again, Part D kind of became available somewhere in between traditional Medicare Parts A and B services and the Medicare Advantage. So the Medicare Advantage being the most recent of those. So the prescription drug program for Medicare is a competitive model where beneficiaries can voluntarily purchase drug coverage offered by private plans. Now, I would also just note that may be limited by available choice, of course, but it is designed as a potentially competitive model. So we've got Part D enrollment is for a calendar year, and there is kind of an annual open enrollment from October 15th to December 7th. There is a late enrollment penalty for those without creditable coverage, and that creditable coverage just refers to coverage that meets a minimum set of requirements. And that's actually paid monthly after enrolling in Part D. I think it's rolled up to the nearest $10, but I could be wrong. And then it's kind of added on to a person's premiums, to my knowledge. Somebody can correct me later if that's incorrect, but I think that's right. And again, you can find a number of different resources on the internet for this. Going straight to CMS and their Medicare.gov website is probably the best idea to begin with. Part D plans do have some flexibility. So while there may be some minimum requirements or certain constraints, there is flexibility in the benefit package. That is what the deductibles and copays are, what the formularies and what's covered are, prior authorization requirements, and so on. So there is quite a bit of flexibility here. And I would say more flexibility than what I'm probably used to in other parts of the Medicare program. Yeah, I don't want to editorialize on that too. I'm thinking of, if you're used to the variability that exists in the Medicaid program, I wouldn't say it's that far, but it's certainly more than what I'm used to seeing in say Medicare fee-for-service or Medicare Advantage even to a degree. The premiums are also going to vary by plan as well. So the CMS payment plans, the plans submit bids every year in June for the following year. The plans are paid a monthly prospective payment or a direct subsidy, and these are a lot of times the term subsidies used for the types of financing that happens for the Part D program. And it's kind of a per member per month for each enrollee based on the approved bid, adjusted for each enrollee's kind of the set of enrollees, the case mix for that set. The case mix adjustment is based on the prescription HCCs, or prescription drug hierarchical condition categories. And if you're used to looking at CMS programs, you'll be familiar with hierarchical condition categories as a common risk adjustment methodology. And here it's just a specific one that's specific to prescription drugs. So that type of thing is that type of system, the HCC system, is going to include diagnoses. Models run separately based on age, disability status, sex, low income status, and non-community residence. The bid amount includes the enrollee premium, and the premium amount is removed from the CMS payment to the plan. So in other words, the premiums that are coming in kind of offset the CMS payment. Plans also receive separate payments for reinsurance, low income, and risk corridor adjustments. So similar to other parts of the Medicare program, there are some separate adjustments through additional payments that CMS is going to make beyond that prescription drug HCC. All right, policy. So the standard benefit so here in 2024, we've got catastrophic coverage at the top based on paying up to a certain amount, but down at the bottom we've got the deductible. So if you want to think about it, it's kind of like having multiple, if you're not familiar with it, kind of like having multiple deductible points, with each having different implications for what's going to be paid. So you got an initial deductible where the enrollee is paying 100%. Beyond that deductible, once you reach the deductible, then the enrollee is paying 25%. And so that's called the initial coverage period. And then past the initial coverage period, again, once you reach the next point, then we have what was called the coverage gap. And so I was mentioning what used to be called the donut hole or other things, where there was this really serious drop off in what was kind of supported for people and in turn what they had to pay in kind of that serious gap before you hit the catastrophic coverage. And so that middle kind of coverage gap piece now really has a space where the enrollee is paying 25% for brand name, and they get a 95% credit as well. I was trying to think if there's anything else here to highlight. Oh, and the plan pays 5% of the brand name as well. So this coverage gap piece is really, I would say, the one that has been reshaped the most historically. And then lastly, we get to the catastrophic coverage where Medicare is actually paying 80% and the plan pays 20%. And so that's kind of reaching past where you've gone through all of these other levels of payment to the point where the enrollee is really paying next to nothing compared to what they had been in all these other phases. And so again, that's the phase in the gap between the initial coverage period and catastrophic coverage used to come with quite a bit more bite to it compared to what there are now, but it's been chipped away at in various ways more recently, particularly as part of the Affordable Care Act. So the true out-of-pocket spending, which is mentioned on the last one, are medication costs that can be used to calculate the beneficiary payments. So the true out-of-pocket refers to things, it might include the beneficiary's own out-of-pocket spending, but it could also include things like if things are covered by a family member or an official charity. It can also include supplemental drug coverage provided through qualifying state pharmacy assistance programs, or through, if you're more familiar with the Part D program, the LISs or the low-income subsidies. Could also include manufacturer discounts in that coverage gap period. And then under CMS's demonstration authority, we also have supplemental drug coverage that's paid for with Medicare Advantage rebate dollars. So the true out-of-pocket cost kind of refers to, it's not just looking at how much has the enrollee or the beneficiary kind of pulled out of their own pocket literally, but rather all the kinds of ways that have been kind of brought together to help pay for prescription drugs, which of course in the United States is a big challenge. So it's used by CCW to calculate the benefit phase that each drug fill falls into in the prescription drug event data files. So you'll note this in the event files. One of the things you'll see is that you can look at where does each drug fill fall in what phase. So going back to this figure, you'll see that a drug fill may fall into the deductible phase or the initial coverage period phase or the coverage gap phase and so on. So those types of true out-of-pocket is used to calculate kind of what phase that drug fill falls into along the way. And so that kind of becomes cumulative over time as more and more costs get paid for. And among those, I mentioned the LIS or the low-income subsidy. The benefits are help in paying for Medicare drug plans' monthly premium, any yearly deductible, co-insurance, or co-payments. There's no coverage gap liability. There's no late enrollment penalty. And there is a very small copay in the catastrophic phase. To note, regarding the LIS, there's been a big effort on the part of CMS and advocacy groups to inform beneficiaries about the low-income subsidy available to them to help pay for Part D services. Because it's available, we want people to actually take advantage of that. Again, given that a lot of people do struggle with prescription drug costs. Benchmark plans are available to LIS or low-income subsidy enrollees with $0 premiums. Other plans will require at least some premium, maybe small. So we've got these kind of different limits for true out-of-pocket, where we've got, starting at 0 up to 545 to reach that deductible phase. Then we've got total drug spending at $5,000 for the initial coverage limit, or the ICL. The true out-of-pocket spending threshold to get past the coverage gap, you can see, really does get up to quite a high amount. So you imagine that going through a year, prescription drug spending in the true out-of-pocket, so regardless of who's paying for it, does get pretty high at $8,000 before you reach the catastrophic coverage. So another way to understand this is if you're familiar with high deductible health plans or something like that on the private insurance side. This would be like a very, very kind of high deductible type plan before you get to some safer phase up in that catastrophic limit. It's just that these other limits are not strictly deductibles. They're kind of these different coverage limits kind of act in ways differently depending on what phase you're in. But you can kind of see where the breakdown happens in terms of the dollar amounts for true out-of-pocket. Prior to 2024, low-income subsidy beneficiaries paid 5% of costs during the catastrophic phase. And so that's changed. The Inflation Reduction Act of 2022 eliminated that 5% coinsurance requirement in the catastrophic phase beginning this year. So in terms of the data files, that will take time to show up, but it has happened. So we've got these kind of standard benefit thresholds that have changed over time. And so the point isn't that there are different thresholds in this figure, it's that there has been change over time. So you note the deductible has gone up from 2006 initially to 2024, more than doubling. We got the initial coverage limit has also gone up, again, slightly more than double. The true out-of-pocket threshold at the catastrophic coverage limit has gone up to 8,000 from an original 3,600. And then the total covered drug expenditure at the catastrophic coverage limit, so that the total covered is up to 12,447. So it definitely has changed over time, tracking with, of course, inflation and other things, but also costs for healthcare in the United States and so on. The coverage gap, as I mentioned, has closed over time, where if you're looking at particularly brand name drugs, and there are cases where, of course, you don't have a generic alternative, but if you look at the beneficiary costs and the manufacturer costs, and then the plan costs, you've got kind of a fair amount of decrease for the beneficiary up through into 2018. There's a pretty big continuity, and then we can kind of see that it's steady off after that through 2024. The plan piece of that had kind of taken on an increasing share after 2012. So into 2013 through 2018, the plan share increased by quite a bit over time into 2018. And of course, again, that discontinuity where now there's a flat break where the plan is covering that small percentage. And then manufacturers have taken on an increasing share after 2018 as well. The generics is a slightly different pattern, but again, you've got manufacturer kind of covering, you got kind of the manufacturer and plan the plan covering a greater share of the cost there over time, with the plan not having to take on those additional costs. With the manufacturer not having to. We have beneficiaries have some potential different plan choice. They choose plans during that open enrollment period from October on, or they need to provide evidence of creditable coverage. The plan compare can be found at Medicare.gov. It provides information on specific medications, premiums, deductibles, plan quality, and so on. Here's a big thing that I think was one of the I guess partially difficult things that we had to deal with, and I remember dealing with these data, are the low-income subsidy recipients. They may be automatically enrolled. And so there may be temporary plans and then moved into a benchmark plan if they haven't selected one. Or they may switch from a plan they are automatically assigned to. But sometimes that automatic assignation of a plan can result in people, for instance, not knowing that they're enrolled, at least as a potential. And of course, you can't really tell that from the data, but you may end up with patterns where people haven't used. And if they're under a low-income subsidy, the question could become, does this person know they have prescription drug coverage? So that's, I think, part of the effort around trying to increase awareness of the low-income subsidy as available at the very least, if not, the fact that people are getting enrolled. Or if they know they're enrolled, but they don't know exactly how the benefits work or those kinds of things. So I think that automatic enrollment, at least for me, was one of the big kind of challenges in terms of interpreting data patterns. So I would pay attention to that. We have standalone prescription drug plans if they are enrolled in fee-for-service. So the kind of the PDPs that I was mentioning. The Medicare Advantage plan then includes Part D coverage, or MAPD. Special needs plans are MA plans designed based on dual enrollment, chronic condition, or institutional status. In addition, we've got plans related to employer retiree benefits. They may be PDP or MAPD, so they may be traditional fee-for-service or Medicare Advantage. Those are offered by employers and unions to eligible employees and retirees that are not open to the public. And there are a couple of different types of those. for the employer group waiver plans or the employer or union direct contract Part D plans, which are self-insured. The average Medicare beneficiary has a choice of nearly 60 Medicare plans offering drug coverage in 2023, including 24 standalone drug plans and 35 Medicare Advantage drug plans. Okay. So we've got a fairly large number there. Note that the availability of standalone, if you look over time from 2007 onward moving up, has kind of decreased on average. And if you'll note, particularly in the more recent years, you've seen a fair amount of growth on the availability of Medicare Advantage drug plans. The weighted average Medicare Part D monthly premiums and annual deductibles by plan type are going to vary. We have PDPs, again, those are the standalone prescription drug plans under traditional Medicare. Moving to the right, then we've got the Part D portion only of an MAPD plan. We got those premiums. We have the MAPD premium among non-zero premium plans, again, the Part D portion only. Then we got the Part D premium overall, the PDP deductible, the MAPD deductible, and the deductible overall. So if you look across and down, you can note that, for instance, a standalone prescription drug plan premium at the far left has gone from the $26, and that's this again average monthly, $26 up to $40, where for the same type, that is the PDP, the deductible has gone from 107 to 411. So that's the weighted average annual deductible. So we got a monthly premium of 40 and a weighted average annual deductible of 411 down at the bottom. And of course, you've seen some changes over time in each of those. Checking the time. All right. All right, in 2023, and this is from Kaiser Family Foundation, so you can go to kff.org. You can find these. In 2023, Part D enrollees will pay a much higher cost sharing for brands and non-preferred drugs than for drugs that are generics, and a mix of copays and insurance for different formulary tiers. So we've got formulary tiering as well as differentiation by generic versus brand and non-preferred drugs. So you can kind of see there's a bit of a range between the lowest cost sharing amount among the national PDPs and the highest cost sharing amount, depending on which category you're talking about. So among preferred generics, which would be typically the cheapest class, I got a pretty small range there. Whereas if you're looking at say non-preferred drugs or specialty drugs, you've got quite a bit of variation there. As well as copays and co-insurance, right? So once we move away from generics and preferred drugs, we've got quite a bit of variation and spread on the lowest and highest cost sharing amounts. And then lastly, the objectives of the workshop are related to understanding the Medicare Part D program and its benefits, understanding Part D enrollment, and linking information available in the Master Beneficiary Summary File. For those who are not familiar, the Master Beneficiary Summary File, or the MBSF, is the kind of master enrollment file or the denominator file for Medicare enrollees. And so it'll have information on enrollment, not just in Part D, but also, of course, in Parts A, B, and C as well. So using enrollment and linking information that's available there is a good place to start to form a denominator to ensure that you've got correct enrollment-based kind of analytic sample. Also, we want you to become acquainted with the processing of Part D event data. Just like all the other files that people will work with from Medicare, the Part D event data have their own structure and their own learning curve, and so there is some time spent on that. Lastly, we want people to understand the content of what's in the Part D event file. Again, like all the other files, the exact availability of information and the type of information and content that are in the file are sometimes intuitive and sometimes not. And there's always a learning curve as people pick up new data files that they haven't used before. And so we're trying to make sure, again, that not only in kind of processing and getting ready to use the Part D event data, but also the exact information that you're actually able to draw from the Part D event file. Again, that's going to be intuitive sometimes and not as intuitive other times. So we'll spend time on that. We also want people to understand the availability and content of the Part D characteristics files, as well as the challenges and opportunities associated with using Medicare Part data for research, and the Part D variables that have been created for researchers, keeping in mind that Part D files, as well as any of the other data files, originally come from the administration of a public health insurance program, right? These don't exist originally for researchers. So looking at the variables that have been created specifically for researchers is useful. Then beginning to think about how Part D can be combined with other Medicare utilization data for projects, right? So how do you combine it and link it and so on?